taking myself off mute. I'm down here at the KGM clinic at the satellite clinic, and Nikki and I are both trying to figure out how to get the webcams and everything to work. But I just wanted to say too that this program, really, the providers recommend the patients or talk to the patients about it, but you guys all are the ones that are really in the trenches. And Tammy's been a great partner to work with because we've been trying to make sure that our referring providers know what all of you guys can do, and we're sticking up for you with things like making sure the consent piece is done correctly and such. So it's been a fun project to work on, and I think there's a real potential for for this program to be really rewarding. And throughout this presentation this morning, I'm going to be asking for Christina and Linda and Hugh, who have had experience with the actual nuts and bolts of the remote, but also I have the chat open, and will also be asking for the RDs. While they have not been part of the remote monitoring charging for it, they have had many patients that they have started on CGM and have worked with on CGM. So we have a great team to build from and get support from. So what is remote monitoring for the newbies? It's a program that was really well timed with the pandemic. The whole idea is that we can train our patients to use some devices such as continuous glucose sensors, but also blood pressure devices to remotely collect information and for the provider to look at it and to make changes in therapy to optimize the person's health. And we happen to be rolling this out during a worldwide pandemic. And I think there's real value in this technology for really helping our patients. And the other thing about the remote monitoring and all these documents that we'll be sharing is that if we can bill for this time. It used to be if patients got started on a blood pressure cuff and needed to send stuff in, it was the nurse's responsibility to collect it in her busy day and touch base with the physician and get back in touch with the patient. And using this program and these tools, and now in the pilot work, that now that we've moved from the pilot into actually rolling this out system-wide, we will be able to recoup for the institution the time that is actually spent with the physician and the nurse and the dietitian collecting information and reviewing it and then making therapy changes. So let's see here. And it's really cool because it's a team-based approach as well. Okay, and gotta get going here. Okay, this is the outline of the presentation today. We're going to kind of go over the workflow. I'm going to be, we'll be sending out the documents when the program is over. Mika will be doing that for us, the slides, as well as sending you links to the remote monitoring site where the job aids and such are living. Okay. So this is a Visio diagram. Once again, this is something that you will get a copy of in larger print. So, but just to kind of show you, the horizontal lines on this are what we call the swim lanes for the different team members. The yellow one on the top is the clinic, nurse, and dietitian. The green horizontal line represents action items or things that the patient needs to be doing. The blue is the provider that is kind of getting the ball rolling. There is a component of maybe assisting with this work in terms of identifying patients with our panel navigators. And so they have a swim lane. And then, of course, there is the billing component as well. So in terms of identifying patients, and this for the people that were in the pilot, this is some feedback that we got from you guys that it wasn't really clearly defined what the inclusion criteria was and who was excluded. So now that we're rolling it out system-wide, who is eligible? Patients with type 2 diabetes, and they can be on insulin or they don't need to be on insulin. Two payer types, which we'll be getting into in a little bit, require patients are on insulin, but you might have a young person that's really into technology. They've been newly diagnosed with diabetes and their A1C is great, and they're just wanting to use this technology to kind of see how their food choices and their physical activity choices are impacting their glucose. But you also may have a patient with recurring hyperglycemia, blood glucose is way out of target, maybe somebody that's identified by the panel navigator, their A1C has been over 9 for 3 years. This might be a person that would be appropriate for this program, or somebody that is totally unwilling to check their glucose in the traditional way using a glucose meter. Any questions on that from the group about the inclusion criteria? If it's a commercial patient, they don't necessarily even have to be on meds. So being on insulin isn't a requirement anymore, okay, for a commercial paid patient, or they can just be on metformin. Who is excluded? If the patient is seeing an endocrinologist at the Diabetes Institute or Northwest Endocrinology up associated with the Northwest clinics, the Northwest campus, these would be people that would be excluded. Down in KDM, Becky, I think you do have some patients that might see a endocrinologist in Puyallup or Federal Way. So if they're being seen by an endocrinologist, we're not going to enroll them in this program. Pediatric patients can use CGM, but they will not be part of our remote monitoring pilot, okay? People with gestational diabetes, and many of our dietitians have worked with women that have GDM and they're on CGM, but they will not be part of this pilot. But that doesn't mean they can't use personal CGM. And then people with type 1 diabetes would not be included in our pilot. Okay.
Hey,
Does
Allison,
it?
can I ask a question about that?
Yep, absolutely.
Great. So only because a bunch of patients here at the Ravenna Clinic also are receiving, have been referred to or have been receiving care at the Diabetes Care Center, the DCC, because it's so close in proximity.
Yep.
And my provider is doing panel management meetings. There's a bit of like, should you be involved? This is the DCC. And so I imagine there might be some patients who either have followed up with DCC or maybe still do, either regularly or intermittently, that I might get referred from the provider saying you should reach out to them and enroll them in this. What's the rationale, I should say, to them about why they're excluded from this service?
Because if your PCP at your clinic has decided that they need to go to the DI, that endocrinologist is managing their diabetes.
Perfect.
Now, you might, they might, what I would do is I would say, if your patient is talking to you and they say, I want to start on CGM, what I would do is say, send a MyChart message to your provider and say that you want to start it, and can they start it down there with one of the nurses? Or let's say, if the patient said, if they're not wanting to be in the remote monitoring, if they just want to start personal CGM and not be part of the remote monitoring, you could say to the patient, ask your endocrinologist if it's okay if I, start you on the CGM, but they can't be in remote monitoring.
Right. So I could teach them how to use the Libre, but I wouldn't be doing the CGM part because I'm not technically the primary care provider on whose behalf I'm working is not actually managing their diabetes.
Exactly. So
Perfect.
it's on the onus, it's on the patient to connect with their endocrinologist. And it might be that their endocrinologist orders it. They just bring it in to the clinic and they show you, and you show them how to use it. But they cannot be part of remote monitoring. And I would refrain from doing any teaching at all on the patient until you get the green light from the endocrinologist that it's okay.
Okay.
Does that
Super
make sense, everybody? Tammy, do you agree with that?
Yeah, I do.
Okay.
Yeah.
Thanks, Allison.
Yeah.
Allison, I've had a situation before where my provider at the clinic refers them to endocrinology, but there's a long wait and the patient wants to be started on CGM before they go to endocrinology. And
that's
then
a
the provider asks
situation.
if I can start it. And so I have.
And if they've already,
They're not established. Yeah.
Yeah, and I guess if they're not established down there, then the endocrinologist is not taking care of them yet. So I don't think that would be a problem at all in that situation. But if they have established care with the endo, we really need to let them know what's going on in their sandbox. Does that make sense? Just run it by them. And you're right, it's going to be way, way easier for the patient to get trained by you on how to use it than waiting to get a nursing visit and all that's entailed down there. So if they haven't established care, you can do it. If they have established, check in with them before you do anything. Okay. So this is just in terms of like, if a provider's in an appointment with one of their patients, I mean, the main person that's going to be talking to the patient about this is the PCP. And what happened with the training that's been going on with the providers is Crystal, who's in charge of this program, has been going over what the benefit coverage is, because Linda and Christina and Hugh can all tell you from personal experience, if a patient that doesn't have coverage is told that they want them to use this program and they're not covered, it's a big time waster for everybody to try to get coverage when it's never going to happen. And then you set the expectations with the patient that you think it's good for them, and then they can't get it from their insurance. So commercial insurance, anything goes. There is great coverage. Newly diagnosed, high A1Cs, interested in what's going on metformin, on a GLP-1, not taking insulin. It's very robust, good coverage. With this pilot, they have to have a diagnosis of type 2 diabetes. So we're not putting patients with pre-diabetes into remote monitoring. They have to have a diagnosis of type 2. Okay. Medicare is a little bit more complicated, and that's why we have our veterans that are going to help everybody as a resource. If a Medicare patient wants to, for a Medicare patient to be able to utilize CGM, they have to be taking 3 or more daily doses of insulin a day via injection or an insulin pump. Okay, that means basal and mealtime. If they're just on basal, they're not going to get coverage. Okay, if they're taking 2 shots a day, they're splitting their basal dose. That's only 2. They are not going to get covered. They have to be on mealtime insulin as well as long-acting insulin, 3 or more daily doses. It used to be, and Hugh and I had an email about this a couple of weeks ago, we used to have to collect blood glucose log histories. The patient had to be checking 4 or more times a day. Medicare is no longer requiring BG monitoring documentation. Okay, but they have the 3 or more doses of insulin a day is a requirement. Somewhere in the note, the provider has been told that they have to put in there somewhere in the note that's going to be sent to the durable medical equipment company, which we'll be talking about in a minute. The provider has to put somewhere in their note that they think the patient would benefit from this technology, and they've been trained on that. Medicaid is very, very difficult. The patient has to be checking 4 times a day, and that has to be documented. I'm not sure, Mika, why it says Medicare provides 3 strips a day on that line. We missed that. So the patient has to be checking 4 times a day, and they have to be taking 3 or more doses of insulin a day. And somewhere in that chart note, the provider needs to make a statement that they feel that they would benefit from this technology. Okay. In terms of patients that don't meet the criteria and they say, well, I want to be part of this, but I self-pay, the provider would send the prescription for the Libres to the local pharmacy where the patient goes. And the patient has 2 options for self-pay to reduce the cost. They can call this customer service number and request a discount voucher. If the patient, though, states to the customer service agent that they have Medicare or Medicaid, the Libre customer service people will have to say you don't qualify because they cannot discount costs to a federally insured or a state insured patient. So the other option is to ask the pharmacist, once that prescription has been sent to the local pharmacy where the patient goes, to run the prescription through GoodRx and tell the pharmacist to run that as a primary pharmacy benefit. And that usually our Libre reps in town tell us decreases the cost to the voucher cost, or pretty close to it. Does that make sense? Have you guys ever had patients that have used GoodRx?
Yeah, but when I tried to get the cost for the Libre 2, it wasn't on there. So I don't know. And it's probably been a month since I last checked.
For GoodRx?
Yeah.
Yeah, it should be in there, Becky.
Okay.
Yeah. Okay. Now, in terms of what's happening, so if a provider is sitting down in their visit and they think that Mr. Smith would be a good fit for the remote monitoring, the provider will go through what the program involves. And this has to be in an interactive appointment. The provider needs to obtain consent, kind of like with our behavioral counseling COCM. The physician, the APP, is the one that obtains consent. It cannot be done by the nurse, and it cannot be done. It says here, Mika, we missed that too. It says provider can obtain consent via phone call. It cannot be done during an e-care interaction. It has to be in-person, telemedicine, or phone, because the patient has to be able to ask questions in real time. Okay, so the provider thinks Mrs. Smith would be a good fit. The provider explains the program. The provider consents the patient. There's a dot phrase that the provider uses to do that. And then the provider is going to go to Meds and Orders in Epic, and they're going to type in referral to RPM, and that will pull up a referral shell, just like, you know, a provider will refer to care management or to nutrition therapy or to diabetes education. And RPM referral is a shell is there, and there's a drop down choice of CGM. In the future, there'll be a hypertension choice as well. But so the provider consents, the provider places the referral, and then the provider is going to CC the chart to either the RN at the clinic, who's the lead, or the RD, who is the person that is doing this work for the clinic, because not every clinic has an RN right now. So at those clinics, you know, the RD will be the lead. I think at KDM, initially, Tammy, the charts will be CC'd to Becky and to Deb as this is being rolled out. I'm not quite sure, Tammy, what was decided at Ballard. Whitney is at Ballard and has experience with CGM. Or if they're going to CC both of Whitney and Stephanie, or
the preference right now is that they CC both, because I mean, sometimes the patient might already be seeing the RD, and hopefully the provider knows. But if we CC to both, we hope that the RN and the RD will communicate to decide who's going to take the lead on it.
Okay. Now at the Woodinville clinic, where this is well established, Linda and Christina, I believe, are the ones that are getting the referrals. And this referral, why we want it to be CC'd, is the referral is deposited in the clinic care management work queue. And I can show the dietitians where that is at a future meeting. If you guys are looking for referrals, for us for medical nutrition therapy or diabetes education, if you just type into the work queue search bar, UWPC, KDM, care management, it will pull up the work queues for those, but I can also show you. But we wanted to go over the process that the provider is using in case, for example, you get a patient that's CC'd and you see that they haven't been consented. We want you to know the process that the provider has been instructed on using. The last bullet point is there is a smart text phrase that the provider will type into their encounter visit that will kind of give the patient a kind of an overview of this program that they've agreed to be enrolled in. Any questions on what the provider is supposed to be doing, you guys?
Hey, Allison, this is Hugh again. I believe I wasn't present in the meeting, that the presentation that Crystal did with the chiefs and the participant in phase 1, and I'm pretty sure that she also included in that telephone and e-care could be used for consent. So that's probably, I think that information's already kind of gotten out to at least some of the providers. So that probably, I'm pretty sure, only because I remember being like, I thought that weren't doing that. So that might require some
Tammy, do you want to chime in here about the provider training at Tammy and I have been listening in on the provider training.
She did. I think I emailed you, Allison, that first, that training, was it the chief and manager one, Hugh?
Yes.
Yeah, she did say that in that meeting.
Okay, good.
But now when she's going around seeing the providers, I noticed she didn't say that. Matter of fact, it came up and she said, "Oh no, we're not doing e-care because it needs to be some kind of face-to-face." She clarified it in the last two provider meetings I was in. She didn't do that. She did do it in the chief and manager one though.
Awesome. Great. I just wanted to make sure, only because in my experience, and the other folks who did the pilot can chime up, no matter how much good training there is, inevitably the point person, either the RN or the RD, is going to get a question from at least one provider about, how do I do this? Or just kind of, here's a patient, do it. And you're going to look and none of this is going to be in the chart and you're going to have to do some re-education. So everyone being on the same page, particularly if you get some pushback from a provider of, well, I'll just send them an e-care message, or, oh, I'll just add it to the chart. Yeah. It's helpful to sort of know what the expectations are, particularly if you're pushing back a little bit.
So in the initial of this, two key things. Nurses and RDs are not getting consents, and the consent has to be some sort of face-to-face communication, telemedicine or in office. Anything e-care? No. Okay, because they want to make
the bottom line, the patient has to be able to ask
questions, right?
And what I've done in the only moment in which that became awkward for me, just a sort of tip and the tricks, is when I sort of communicated to the provider, I said, listen, the patient's going to be coming in to do the education with me. So if you want, we could sort of pair either with a visit for you, or if you want to pop in and sort of somehow do that you know,
And
when the
addend the
patient is here,
note or
and
something
addend your
like that.
note, but like you just need to, like, I'm happy to work with you to make that happen. So I'm not seeming like a barrier, but at the same time, this is the kind of part you need to do. And I didn't have much. That was a helpful tip for this provider that I worked with, but not sure if everyone's experience was like that in the pilot, but that was at least something I wanted to share.
So that's a great workaround, and that's why we're so happy with you on the phone on the Zoom training, because providers don't like consenting patients. I mean, because they have to start talking about, you know, the patient might have a copay, right? So that's you know, that's part of it, but having the patient, if you're doing the in-person device training, having that provider pop in, or, you know, facilitating getting a phone consult set up or something like that. Yeah. Okay. So, and this is kind of redundant, but also in those monthly panel navigator meetings where the panel navigator is looking at the provider's panel of patients, she's sharing with them who has care gaps, such as this patient's had an A1C over 9 for 4 years. At those panel navigator physician meetings, you know, the panel navigator could say to the provider, what do you think about this person for RPM? Because once again, those providers know their patients the best. You know, if the provider does agree, you know, the panel navigator can add a note to the upcoming scheduled appointment that this might be a good patient for the provider, in that note scheduling of the template in Epic that, you know, RPM, CGM, you know, so as a way to remind the provider to bring it up. So, and then if you, as a nurse or a dietitian, if you are working with a patient that you think might be a good candidate, you could send a message, you know, via secure chat, staff message, walking over to the desk of the provider and asking them to, you know, review if they think the patient would be a good person for this remote monitoring work. If the provider agrees, the RN or RD could maybe try to help facilitate getting a phone consult set up to have that provider do the consent. And once again, if the provider is consenting the patient during that consent visit, the provider can place the referral for CGM, because he or she has to do that too, right? For the remote monitoring pilot. And then during that consent phone visit, you know, or in person, the provider can also place the prescription orders. And Tammy and I both thought, when we were reviewing this training stuff, it's not your guys' job to be pending all this stuff for providers to sign. You know, if they think the patient is appropriate for this, you know, as much as possible, you know, having them do the consent, the orders, the referral. Any questions on that? And Becky has something here in the chat. I have a provider that documents type 1.5 diabetes. Is this person eligible? If the patient has type 1 diabetes, I would probably say no, Becky. I think type 1.5 is probably more like a type 1. Often those folks often see an endocrinologist too, unless do you have a provider that's thinking about having that patient enrolled, Becky?
No, I see a lot of that documented.
Some providers call them 1.5 if they have type 2 diabetes and are on insulin. There's no evidence to suggest that there's anything else going on. So sometimes it's kind of just a term that is used as opposed to anything. Is that what we're talking about here, Becky?
Yeah, I think so.
Mm-hmm.
Yeah, so if the diagnosis in the Epic, you know, in the diagnoses list is type yeah, to Deb's point, sometimes the providers say if somebody's on multiple daily injections with type 2, they have type 1.5. So, and that's something, Becky, if there's a patient like that, you could email, Tammy and I, and, or, and we could kind of help you try to work it out with you. Okay. Okay.
We can also go ahead and just ask Crystal to see if we can get some guidance on that, just to be on the safe side too. But because in the training, she needs to be aware of that, so she can talk to the providers about that and get some guidance on that. So they
Yeah.
either
No.
either they can refer or not. So I can send her an email now, actually.
And Tammy, actually, maybe that's a good thing.
Or I tell you what,
can you
I'll
make a list?
yeah,
And
I'll make
keep
a list
going?
Yeah, I'll keep a list.
I see that there needs to be a couple of tweaks to the slides as well. So in terms of ordering the device, I know I've kind of talked around this a little bit, but this is a slide that is just totally devoted to, based on the insurance type, how the physician or APP needs to order the Libre 2 sensors. So commercial insurance, they order it like a medication, preferably sending it to their local big box pharmacy. Medicare, they have to use a DME form. We don't get prior authorizations for Medicare. It's a DME form. We have them located in the remote monitoring list of resources. They're also available on the shared drive, and Tammy and I and the local clinics can show you where there's a link when I send you the slides, that if you right click on it and open it up, it'll take you to that DME paperwork. Okay. With the DME paperwork, the provider has to choose the type of diabetes the person have. You're going to have to print off some forms, probably have to put in there the A1C. There's a list of DME providers that all this information, the chart note, the signed form, will need to be faxed to. And this will be something that we want to try to have the physician, if they are actually ordering the device, they've been trained on how to find this form. So hopefully the first time the nurse or the dietitian at the clinic, they see one being walked over to them that's been signed already by the provider in a perfect world. And then once again, probably the nurse or the dietitian at that clinic will be collecting the chart notes that need to go to it, and then choose a DME provider from the list that's on page 2 of the DME form. Hugh, Linda, and Christina, have you had better luck with DME companies than others? Are there some that you like better than others? Because I know you guys are the dietitians that have done a couple.
Not necessarily. I don't have a favorite. There can be a bit challenging at times if you don't have all the information that's needed. You have to make sure you have every bit of information.
So you're talking about the paperwork, but I'm saying, is there a DME company? I think there's Advanced Diabetes Supply is one that's a go-to.
Okay.
And then Byram's another one.
Yeah.
Sometimes the patient's insurance company will dictate which durable medical equipment that the patient is required to use. So sometimes it might take 1 or 2 tries to figure that out.
So it's up to the nurse and the dietitian to fax all this stuff off to the DME company, or can we have I've been having the MAs do it.
Well, you can do it. I mean, you can do it, or you can have an MA do it, depending on, MAs at your clinics. Some clinics are like Woodinville don't have a lot of MAs anymore, Ravenna and things like that. So yeah, somebody's got to get it faxed in. And one of the things that I would recommend is scanning the completed paperwork and storing it in the media tab, just in case you have to choose a different company once it's already been filled out. There's
That's
a
a great
copy of
idea.
it. Yeah. Or you can, it's just there and you don't have to be tracking that doctor down again. Now, Medicaid, the prescription for Libre is sent to the big box pharmacy. And what the patient needs to do is it needs to get run like a prescription for insulin or Lipitor. And what will happen is once they run the prescription, that pharmacist, what they're going to discover is there needs to be a PA that's completed. So PAs can now be sent to the PA team. And let's see here. There's a job aid that let's see here. In the job aid, on page number 4 of the job aid, it says here, it's got really detailed notes. So I would encourage all of you to print out the job aid. And I'm just going to read it right here. PA. If PA is required, route the PA authorization route request to PA Authorization Center, which is UWPC new PA request. So it's all outlined in here what to do with a PA. Okay, you guys, in that job aid. And the reason why we didn't put it on the slide is that we are gonna, Christina, we want you to print off this job aid because this is going to be kind of like your Bible. And it's just so we didn't have to put too much detail on these slides. So print off this job aid for sure. Yeah. And, just kind of keep it handy. And part of this pilot, we found out that insurance coverage from you, Linda, and you and Christina, that insurance coverage was the biggest time thing for you guys. And so we pulled in Ellen Kahn, who is in charge of kind of insurance coverage and the PA team and the referral team. And she went through, and in this little Bible, in your job aid, it has step by step, and Ellen has vetted this with the referral team and the PA team. So it is going to be your go-to document. Okay.
That's awesome.
And that's something where, as your providers are learning about all this, you guys, you might have to correct them and redirect them. So Medicare is a DME. Medicaid, the prescription goes to the pharmacy and the local pharmacist runs it. They might just say there's no coverage at all, and then you're done. And if it says PA required then you need to get that PA sent to you, faxed to you, and then you guys need to send it on over to the PA team and they will take it from there. Does that make sense?
So doesn't the pharmacy automatically send the request to the PA?
Well, you
to the
might, when
clinic,
you're
or-
talking to the pharmacist, that if a PA is required, that PA, that document, usually the PA is on a form, Becky, and it's faxed to you from the pharmacist. That PA needs to get over to the PA team. I don't know.
So we have to watch for it to come in, is that it? Or, I mean, because how would you know that they've sent the PA?
Does somebody send a, I mean, they have to fax when you guys do PAs at your clinics, do the PAs come into some centralized location?
Yeah, it comes into the front desk handles those,
Yep,
and then
yep.
they send them off. And so I never see
Okay,
them.
okay. So then you never see them. Okay. So it sounds like there's a system in place for them then. Sometimes the doctor has to do some documentation and sign it, Becky, and you might have to gather some chart notes. So that's where, if the CGM PA comes in, and you're going to probably know about it as the nurse, or the dietitian at that clinic, because you're going to you've been CC'd on this chart and you'll have noticed. So you might be kind of watching it. In all the 3 clinics, I think we had 23 or 25 patients, Mika, total. So it's not like there's going to be busloads of people getting into this program, at least initially. So, and Medicaid coverage is so difficult that it's going to be a fewer number of patients, but you might have to track it a little bit with your front desk and have them be on the lookout for it. It might go to the provider's box then if it's something they have to fill out, so you guys can be working together. Has anybody had a PA for Medicaid yet, Hugh?
Yeah, this is me. So I mean, I agree with what you said, Allison. The numbers are pretty low. Since it was a pilot, I did take a very active role in ensuring that everything went through. So I didn't hand off paperwork to the MAs. I sort of largely did it myself. It wasn't that hard, and because I really wanted to help kind of understand the process to be able to lead anyone else through it. I think I only had one person who was just straight Medicaid and didn't also have Medicare, and so I think what ended up happening was the patient said, the pharmacy told me it's not covered. And it was kind of through me trying to work with them around scheduling them to come in for teaching that I was able to figure out the hold up here is around their insurance coverage. So I ended up calling over the pharmacy and they said it's not covered. I said, it's not covered, does it require a PA? And they're like, oh, it requires a PA. And then I knew from our training that we had the Molina sort of Medicaid prior authorization form. And so I just worked with the provider to get it filled out and sent over. So it really was the minority. I think it probably was only one of all of my patients. And I really cared about this patient and really wanted to help them sort of get access to it. So I sort of did the extra step. I'll be interested to see if it ends up sort of going more smoothly in the future through this sort of PA process. But, that's just sort of my experience.
The DME will be done by either an MA or an RD or an RN, helping collect those forms and getting them faxed over to the DME. We were told that the DME for Medicare patients will not be done by the prior auth team, only PAs. Okay.
Yeah, and the DME for the medic, I mean, the first time took the longest, but I mean, it's not that. It just add a couple minutes onto sort of my phone call with the patient, enrolling them in scheduling the sort of process. So yeah, not that hard.
Yeah. And then just highlighted down here at the bottom, if the patient uses a smartphone, you'll be teaching them, and we'll be talking about that, to download the app. But the patient that doesn't use their smartphone, we have to make sure that the provider knows to order a receiver as well. So they're going to definitely send the prescription over for the Libre 2 sensors, but they're also going to, if a patient's not using their smartphone, have to send over a prescription for the one time only, like reader.
And sorry, just to jump in on that, it also depends on the smartphone. Something that I've learned is that and I see someone else sort of nodding, if your smartphone, I'm someone who had a iPhone SE version 1, a 6-year-old phone, and it turns out that my phone did not have the capacity to download the Libre app. So it just depends on how smart your smartphone is. I've since upgraded. Don't be mad at me. I've got a nice new phone, but that's another sort of step to get involved with this. I think the RN and the RD sort of do is helping make sure the patient has the right smartphone, because some of our patients, understandably, particularly some of our patients with Medicaid, buy the sort of very cheapest sort of phone possible that looks like a smartphone, acts like a smartphone, but doesn't actually have the capacity for the app.
And just to add to that as well, through troubleshooting the process, is some folks think that they can have both, download the app and have the reader at the same time. And Hugh schooled me on that. You kind of have to pick one and be loyal to one process.
Yeah, and
per sensor, you can change back and forth per sensor, right?
Yes, per sensor. If you start the sensor on your phone, you have to keep using it with your phone. And then if you start it with the reader, you have to kind of keep using it with the reader. It's like they get married for the 2 weeks.
And then when the 2 weeks come up, you have a chance to
consciously uncouple.
to go date with somebody else, right?
I
Yeah.
thought you could, if you started with the reader, you could then use your smartphone. And then, but if you started with your smartphone, you couldn't go to the reader, is what my understanding.
Per sensor, Becky.
Yes, yeah. per
Each
sensor.
sensor, you have to decide reader or phone.
Okay.
And in the job aids somewhere, and I had Mika put it in there, what the latest and greatest compatibility is. So that's definitely something. Mika, can we add that to the job aid? Because
Yes,
that
Mika.
sounds like that is on the website, but let's, if you, I'm looking at this, Mika, we already have it in there. Page 4 of the document, it says smartphone compatibility overview. And then there's a link to it. So if you guys look at these, look at the job aid when it's online, right click on that active link, you can print off that form and then include it in your stuff. And I will also try to make a note to pull that information out and maybe send it to everybody too. But we did think about that in the Bible about compatibility. And then you can just ask the patient to look at their settings or their, for their device and see if it's going to be compatible or not from the get-go, to Hugh's point. So, okay. This is another thing that I would probably print off at your home clinic and maybe tape it to the filing cabinet or the wall as you're getting started on this. It just shows you the referral workflow for the provider and the RN or RD that just really kind of, really hones in on whose job is to do what. So, okay. Let's see here. So any questions kind of on the process, the workflow, the ordering, things like that? So now, if there's no questions, we're going to pivot to the intro meeting with the patient. So the first thing that you're going to want to do is, you've got the chart copied to you. You see the provider's consented the patient. You see that the referral is made. The RD or the RN will then call the patient and schedule an appointment. And probably the first thing you want to do is probably make sure that the patient has their equipment. And it might be when you call to schedule the patient, that appointment, that you have learned that the patient doesn't even have their equipment yet and they don't know what you're talking about. So I would wait to schedule an appointment until the patient gets their supplies. Okay. So
Allison, I have a question.
Sure.
So the provider is going to CC the chart to us once that is done theoretically. And at that point, we're going to make a DSME refer to diabetes educator appointment.
Nope.
We're not.
Nope.
Okay.
This, the device training, and we'll be talking about that. It's not a DSME visit. There is coverage from insurance payers for the device training.
Okay.
It's not a
So
DSME appointment.
we would need to make an appointment
for the patient to come in because the device training has to be in person. It
Sure.
cannot be telemedicine. It can't be over the phone. The patient has to come into the clinic for the device training and the device setup. And so with remote monitoring, that's when the patient would bring their blood pressure cup and the nurse would show the patient how to use a blood pressure cup. So that device training appointment needs to be conducted face-to-face, one-on-one in the clinic. Hugh, question.
You know, if my face pops up, I have a question.
Yeah.
Is that a us policy thing, or is that a billing thing?
That's a billing thing.
It's a billing thing. Okay.
Has to be face to face. Now, you can do the device training, and it says here the intro meeting can be split up into 2 visits. To your question, if you just get the device training set up, it must be performed in person. If you didn't get to everything, you can do the rest of the training about bathing, showering, how to read it, you know, blah, 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 you know, additional stuff can be performed at a second visit, and that can be done over the phone or telemedicine. Because the whole idea about this is it's remote monitoring, but that initial piece needs to be the device training. And I think, Hugh, you had an experience where if you were doing both of them, the device training and the education, the patient might be there for 90 minutes. I think you had some of those experiences.
Yeah, I think it just depends on the patient. You know, there's some for whom it's they really get it, it's no big deal, but there are others for whom that's really a very long visit, depending if they're sensitive, if they're nervous, if there's a lot to sort of grapple with. So yeah, I think I have definitely split that up into sort of 2 visits. But one question is, let's say we have a patient who wants to do this, wants to do RPM, but let's say because of COVID or whatever, like they really are trying to avoid in-person visits. And let's say they're actually not going to come into clinic no matter how much I kind of convince them. Could we do this, both of them or this visit over telemedicine? And with that, could they then still be in the program if this part doesn't happen? If let's say it's not billable, right? But would it kind of
I'm looking at
null-
this billing from the regulations, the billing and coding and billing guide. This is a slide. This is, I'm going to get to this later. This would be another one that I would print off in the color printer at the clinic and tape to the wall. It says here, the CPT code is 95249, billed one time. It has to be initial face-to-face in bold print.
Right.
You can't do it over telemedicine.
I guess what I'm
now
saying
that we're
is-
out of the pilot.
Right.
They'll have to wait till Omicron's over.
So basically, if there wouldn't be a way to basically say this part we're not going to bill, we can bill into like a 99211, but they could still participate in the visit. But that one is that the billing code that has to happen for every other billing code subsequent?
I don't know the answer to that question. If you have to bill that one first, so I would imagine, because it says the initial face-to-face intake visit. So the patient might just choose to get a personal CGM and not be part of the program, and then you would just work with them, Hugh, in a care management way.
And this hasn't happened. I'm just thinking of all the possible iterations that come up down the road and being able to particularly talk to a provider about this is what needs to happen.
Yeah.
We can ask that question, but normally insurers look at things in sequences. This must be done in order for this to be done. And if they don't see this, I used to work for insurance companies. That's how they used to think. I can't say 100%, but if they don't see that first visit, that code, then to them, you haven't done the device setup.
What if they have been using a Libre, but nobody has ever managed their
And now you're enrolling
number?
them. I was just kind of thinking of that.
Because like we got a lot of them and they're like, is anybody?
I've had that happen.
Absolutely.
So
Sure.
do you guys go through the device setup though with them to make sure they're using it correctly?
If they come to us and they've been using it, and we'll review and make sure they're scanning every 8 hours and all that sort of stuff. But people are getting them.
So we actually this Thursday have our monthly billing meeting. So Tammy, we will ask compliance about that. But the way that the regulation, and this comes right from, the CMS website, it says face-to-face. But to your point, you might already have a patient on CGM that wants to be enrolled in the program. So we will find that out. Because what we know from the pilot, the 25 or 23 patients, that is quite lucrative for the institution. And that training appointment is like it bills out at $130 or something or something like that. So it's not insignificant. So we definitely want to get, credit for doing that too. And then to Tammy's point, if things need to be consecutive. So
I've
Yeah,
had a
yeah,
few
Linda.
patients that I'll call them to schedule and they'll be like, oh, I already got it and I got it all set up. And so I'll say, well, I'll ask them a few questions about it. And then the questions are kind of gearing that, well, it'd be good for you to come in just so we can review everything to make sure we've got everything, all the ducks in a row for it. And then some patients will say, yeah, okay, I will. And then others will say, no, I got it. But then I say, okay, I give them my phone number. Then they call me back a week or two later. Oh, I'm having trouble with this. And so I say, well, what's the trouble? Maybe you can come in and we can go over it. And that's how I can oftentimes get them
Okay.
in.
Because the other thing, and this is the part, it says, at that intro meeting, kind of reviewing the program, but the second little arrow point, help the patient set up the device. That's hugely important. And then, but connecting to the LibreView portal, you can't do remote monitoring unless we can get the data. And so part of that, and when I used to work, in the clinic myself, I remember telling my kids, your 60-year-old mother helped a patient, set up their app on their phone and they're like rolling over and falling and laughing and everything, but a lot of them, we have to make sure the app gets set up correctly. And if we have a Medicare patient, they, I'm not Medicare age, but I have a smartphone. But, some people, even though they have a smartphone, you might actually have to be helping them set up. And Linda's nodding her head like
That's the other way I've gotten them in is they're like, well, can you just connect me? And then I can tell they're having trouble. And so that I say, well, why don't you come in and we'll get you set up. And then I kind of review over to make sure they've got everything. So I can get that initial visit.
Yep. And that's where, for the remote monitoring to be remote, we have to have access to the patient's information. So we need to make sure the patient has the app installed on their phone, or if that reader using patient, we need to make sure we find out the patient's preferred email address. We have to send them the email to connect with, and the password. And once you send them the email, when you do the follow-up conversation, and now you guys get to, once we've enrolled this patient, if you do, you're going to say, I'm going to call you in a week. You're scheduling that appointment, and then you're going to actually be able to bill for the time to make sure the patient's, understanding how to do all this when they're sitting at home at their house. Because the whole idea is that this, after we get the device set up, the patient doesn't have to come into the clinic, but now you are being able to charge for your time. I do think Hugh had a patient that could never figure it out, right? And he just, or she, or they come into the clinic, right? With their, and you do it.
Yep.
I have one of those too. Yeah.
Yeah.
Yeah,
So-
basically they scan, but they bring it in and I download the data because it's not going to happen.
But now you are able to bill for that time, for those encounters with that patient. So the patient in that intro meeting, the device setup is the most important, and connecting the patient to the portal via app setup or sending them an email. If you have additional time, then you can start using, your skills as a dietitian or a nurse to kind of review medical history, lifestyle, going over the more subtle nuances of wearing a Libre. Hugh had a really great after visit summary that he used with patients. And then as I troll through the dietitians that I supervise, their smart phrases, I found this really amazing smart phrase that Christy had come up with. So what we did, Hugh, you were gone by now, so I couldn't ask you for permission, but now you're back again. So I'm going to ask for permission after the fact. But we took your note and Christy's note and made a beautiful education plan. And I'll show you guys how to access that. So we got the device training and then the patient education. if you go in a patient encounter to this .cgm RPM RN intake note, it will be kind of, and Becky, I think you and Tracy, when you were doing CGM training, you would kind of have a note where you kind of had all these things kind of lined up and you used it as a recipe, to kind of make sure you were covering points. I know talking to Christy that, if she doesn't cover all the education topics on her smart phrase, she cuts and pastes those and saves them for later for an upcoming visit. So we'll show you, I believe, on the next couple of slides. The EPIC visit type for the nurses is clinical support. The dietitians don't have that visit type as an option. So it might be the patient in that first new appointment, and we'll figure this out with compliance for the RDs. I think your only option is going to be new. So, okay. And this is a picture of what a screenshot of what the smart phrase actually looks like, or the smart text. If you type that smart text little statement in there, and what I would encourage you guys to do is to kind of practice, maybe get a ZZ patient or another patient you've seen, and kind of play around with this new note. They really kind of made it pretty awesome. Most of the time, they don't spend a lot of bandwidth and time and energy creating these beautiful charting notes for dietitians and nurses, but they do for providers. So there's these vanishing tip things. If you go right click on device setup, it's going to give you that recipe, that outline to follow. If you right click on the patient education, that's where that beautiful note that Hugh and Christy came up with lives. Okay. So one of the slides that I would also encourage you guys to print off is there's a list of smart phrases that's going to be near the end of this. And I would encourage each one of you to go to each smart phrase and see if and play around with it, see if you can get it to fire and activate and look at it.
Hey, Allison, I'm
Mhm.
gonna ask you a question. I remember yesterday there was some emails going back and forth about someone was using the smart phrase, and I want to say this one. I think it was this one.
Yeah,
And it
so
didn't
I tried to
populate.
pull this one up myself and I couldn't get it to fire. But I was doing it in a telephone encounter. So it might be that I need to be in a new visit or a different visit type for this one to fire. So that's why I want each one of you to and I will show you when I get to the slide to print off one of these pages and go through each one of those smart text phrases to make sure you have access to them.
Yeah, because that explains, like, I've been doing it too, and I'm noticing I don't get it the way it looks here on the screenshot, but that's the explanation. I didn't hear that in the email yesterday because okay, all right, because I just don't want someone to pull it up. Just know if you pull it up and it doesn't look the way this looks, it's not that it's not working. We just got to make sure that you're in the right type of visit type or whatever.
Okay,
there was one that Hugh used and Linda and Christina used in the pilot that was kind of the Chevy version. This is the Mercedes version. So Hugh, did you pull one up?
Yeah, in my list of smart phrases, it's only the old one. It's not this new one. If I do the .cgm RPM, the
smart text link,
the smart phrase, it's in my smart phrases, but it's basically has the one from that Crystal made back in April 2021. It doesn't look like this. It looks like the old one.
And that's what happened to me when I tried to use it too. It didn't come up that I had privileges to use this one. So
but we just got to figure it out, because I just pulled it up too, and mine doesn't show like the new version.
Okay, so then we don't have privileges. Maybe they just gave it to MDs.
Okay.
Which
wait, so what is the new phrase? Is it still the same? CGM RPM RN intake?
let's see. I'm sorry if I'm making anybody vomit. Okay.
No, I need to
It's-
use it today. That's why I'm like, what is it?
So it's on slide 32. It's RN initial visit. It's .cgm RPM RN intake note.
Okay, it's the same.
And I could not, and so
That's currently not updated in Epic.
oh,
Okay.
you know what though? You know what? It's the same term as the old pilot one. So maybe that's why we have to delete that smart
the old one.
phrase. So that what you are using is a smart phrase, you guys. This is called a smart text. The one with the vanishing tip. So I'm wondering if your old CGM RPM intake note overrides when you use your smart phrase, if it overrides the ability to use the smart text. I don't know if that makes sense, you guys.
We figured it out. Mika, can you speak to what's
And
his
then the
name?
other one I didn't have access to, not that we want you guys consenting. I could not pull up the RPM consent either.
I am typing up a message to IT as you guys are going over this and asking them, RNs and RDs still cannot access it,
The intake note and the consent note.
Yeah.
And there was the name of a person at the bottom of the slide from Jihoon, Mika, that said we were supposed to contact her if we were having problems with access. But the other ones all pulled up for me. But I want each of you guys to try those ones out, sometime this week. Okay, so now I apologize. Maybe I'll do it this way so people don't throw up. Okay.
Hey, Mika.
Yes.
Can you kind of tell them it's a little bit urgent if that's possible, because we have a patient today and it would be great if we could use the new, smart text.
I will tell them to step on it because this should have been done over a month ago. So
Okay, all right, thank you.
Okay, and so moving on to slide number 15. So just so you guys know, when you are working with patients.
Hey, Allison, can you do me a favor?
Yeah.
Can we go back to the other slide? No, it was on the smart text. I mean, just to say it, verbalize, it's the next one.
Not this one?
It's the next one. Go down, go forward to the one where you have the smart phrase, the smart text or whatever. Yeah. The thing about it is when you guys actually see it, you're going to see where the option says device setup. You're supposed to be able to hit either device setup and go through that workflow. And if you can do the education, you could go back and do the education. So you can use it's the same smart text. It's just that there's like a link, almost like a hyperlink, where you hit device setup and or hit education. And it'll take you through both. They're all in the same smart text. Okay. Just wanted to reiterate that. Okay. So it's not a separate one. It's the same one.
Yeah, you can do both or one in the same chart note.
Right.
You have choices. Okay.
Okay, thanks, Allison.
And just for you guys to know, in order to bill for this, your patient has to have worn it for at least 72 hours or 3 days. If you're working with them and spending time with them. So, you can't probably do a follow-up visit the next day. You need to wait at least 3 or 4 days to do a follow-up visit to charge for it. Okay. Okay, and I think we've talked about this already, that you got to make sure that the patient knows how to access either the portal or, if they're doing it the old-fashioned way, we kind of have to walk through with them They need to go into the LibreView portal. They need to, they need to take their receiver reader device that they're using to scan. They have to, their reader comes with a USB micro a cable. They need to connect those two, and they need to be able to pull the data, from that and upload it. And this is where I think Hugh had the situation where, and maybe Christina too, or Linda, that the patient just couldn't figure this part out. And they didn't have teenagers at home or grandchildren that they could have come over and set it up for them. So, but most patients can figure this out, how to take their receiver, upload the data, and create a PDF, and then they can send it to you via MyChart. I don't know if any of you guys have ever done that in your own visits, if you have access or use MyChart, but you have the ability, if you've created a PDF, to add a PDF to your MyChart note, and that's what the patient would do and then send it to you. The app is so much easier, because it goes right to the cloud, but and that's where it might take a little bit longer the first couple of visits with a reader using patient. So.
Allison, also what I found is that if they're uploading at home via LibreView, you can access the AGP report if they're in your practice.
If they're in their practice with a reader?
Yes.
So they don't have to do a PDF. Okay.
If it's basically that's been my, I'm pretty sure that's actually what happens. Yeah.
So you've said, Mrs. Smith, I'm going to call you tomorrow, our appointment, I'm going to call you in a week. Please upload your reader to the LibreView account the night before the morning of our visit. And there it was. Okay.
Yes,
perfect.
exactly.
Mhm.
Also, if you're someone if you have a patient who just can't figure out how to do that upload, and so they bring it to the office, I've found that you have to have a special driver loaded onto a specific computer. Allison's helping with that. Okay, I'm seeing heads nodding, but if you don't know about that, ask Allison. She'll help you figure it out, or let me know. And because it's just an IS ticket and then a click or two here, but it took me a while to figure out how to do that. It was not straightforward.
And I think some of the RDs have it, like Christy, I know, has it loaded onto her laptop. I know Jolene might have the drivers on her laptop, so she can actually do the download right on, her laptop too. But the idea is to be able to charge for it, we need to have a copy of the PDF. So hopefully what Hugh has done is he's created a document, and then he stores that PDF. He went into the LibreView account. It's really easy. You create a PDF, and then you need to create to get that scanned and uploaded to the media tab. And there's instructions coming up on how to do that. And I know this seems like a boatload of stuff, but as Hugh and Christina and Linda have found out, once again, you're being, you've set aside this time in your appointment, and you're able to bill for this time that you're taking to do this work. Okay. So in this, you've done the training, you're connecting with the patient, you've scheduled their follow-up visit. The visit type that we will use from the drop-down menu when you're scheduling the patient for follow-up is patient outreach. And this is something that the dietitians have along with telemedicine and new and phone visits in their appointment visit types. And I know that the nurses have it. Once you get that PDF created, you are going to upload that to the media tab. And this is information that's going to be on slide number 17. Once you get the information, there is a smart text that you are going to use that will bring up this new note called CGM RN follow-up visit. And that is going to, there's a view of what that smart text looks like on slide 19. Once you guys are looking at this with your patient, they're looking at their LibreView download, you're looking at it, you're over telemedicine or the patient's at home and they're looking at it on their LibreView account, you're going over lifestyle stuff with them, right? How's the diet going? How, let's see what happens when you eat a pound of grapes before you go to bed, or let's see what happens when you do physical activity. So you're going to be looking at it for lifestyle recommendations. And then you are going to, when you're done meeting with that patient and looking at their LibreView download, you are then going to send that note. You're going to sign it, and then you're going to route your note to the provider, because the provider needs to evaluate what's going on as well. Okay. And you're going to say in the routing comments, you're going to remind them that the PDF, especially in the beginning, is in the media tab associated with your visit. So then the provider can't bill for evaluation on his or her end unless they make reference to the information in the report that's in the media tab. We have to have that for billing. And then there is a flow sheet. Oh, let's see here. Here's the job aid. I'll just get to this here first. The job aid that shows you on number 2 and number 3 and number 4 about how to upload that to the media tab. And once again, it's a learning curve. Hugh, Linda, Christina, did it take too long to learn how to upload stuff to the media tab?
No, it's pretty easy once you get it down.
It's pretty easy, except if you don't do it that frequently. I found that I need to make myself really detailed instructions with like screenshots, because I would remember how to do it, and then a week later I'd come back and be like, wait, where is that? So because it doesn't come up, it's not a frequently used spot, so you kind of have to click and look in a little bit. So
is that something you've already created a document that you can share with the group?
Yeah, Whitney has seen it, and I think was wanted to have me admitted for psychiatric help after she saw the level of detail. So if anyone wants to look into the mind of a psychotic person, I'm happy to share my job aid with you.
So Tammy, maybe that's something where we need to get a job aid with Mika, so we don't have to admit you for psychiatric help. Mika,
I mean, lost cause, so I'm happy to share my work with everybody.
Well, let's share it with Mika first before and see if we can create a job aid out of it. Mika,
Perfect.
Is that okay?
That's all right, Hugh. If you send it to me, I'll play around with it, and then I will send it to you, Allison, and Tammy for review, and we'll go from there. Does that work?
Yeah. Cool. Because the idea, I know this is a huge learning curve, all this info dump that we're doing now, you guys, but once you've done it a few times, it's pretty, you get there. This is a flow sheet where, if you have time, and we're hoping, through this process, where, and we'll be looking at the AGP reports, but there is a flow sheet where you can put the time and range that the patient's in, and time below range, because we want to avoid hypoglycemia, and the GMI, the glucose management indicator, which is similar to an A1C. I'm not sure why the screenshot says 28%, but it's, but once again, this is something that you can also use with the patient to show progress. You can, create a longitudinal, just like with weight or tracking, you can create a document, easily in these flow sheets to show people how they're tracking and making progress. So
Allison, does that automatically auto-populate that stuff right there?
Nope, you just have to go into the flow sheet and put it in.
And that flow sheet is called Diabetes MA Note. What is it?
Yep.
Oh, okay. That's interesting. Okay.
This is new, right?
Yep, because we used to do the enter edit GMI thing, Hugh, and then we got in trouble for it.
Yeah.
So this is replacing that.
This is great.
How we were doing it before was a compliance issue, so that we had to create This is new. But these flow charts are in the vital data. You know, you just type in the name of the flow sheet and boom, it's right there. So
You guys know how to get to this? Okay. All right.
okay.
Oh, I don't. Is there a job aid on that? Or is it just in the flow sheets and then you just have to, I'll see if I can find out. If I can't find it,
Oh,
I'll
we
email
Once you
you.
can-
go
we-
to flow sheets, just type in this in the search bar in the upper left-hand corner, the name of the flow sheet.
IVs, MA note, okay.
We can
Allison,
add,
I have a
let's
question.
add a slide. Can we add a slide, Mika? I can send you a copy of it.
That would be great if you send
I'll
it.
add a slide that just shows exactly how you get to it.
Yeah, please do, and I'll have it.
Okay. All right.
I feel like
Okay.
everyone is seeing the level of my OCD and it's making me uncomfortable, and yet also vulnerability is power. So, hey,
But
friends.
you know
It's
what?
awesome how you,
So
helpful.
Hugh, what you're describing is what we call RDs, tendencies to OCD. I think every dietitian that's listening to this is like feeling like, what is he talking about? We are this level of detail all the time.
Who, me on my
not
third page
Allison.
of notes? What are you talking about, Allison?
I'm
I
not
fa-
Allison.
Freaking,
Are
except
you
for
sure
Whitney.
Are you
Whitney.
sure you don't want to be a dietitian, Hugh? No.
Hugh's detail was over my head. It
Yeah,
was
Whitney-
good. It
Whitney
was
came-
helpful.
Yeah, Whitney comes over and just sort of is just like, hey, bud, what you worried about? You know, it's great.
Put your head between your knees for a minute,
Yeah.
right? Yeah.
Whitney's our Care Bear. She's the one who
The best. She's
Hugs
so
us
powerful.
down.
She just sort of, so powerful. I love it.
Not
we
really.
love you, Whitney.
Okay.
Oh yeah, you are.
So this is what the smart text of that follow-up note looks like. So it just shows you, so you're going to be looking at the AGP report that you've generated in that PDF with the patient, and you're just going to F2 to the little 3 arrows, and you're going to put the date range of when the date range. You're just going to take it right off with the report. F2 to the GMI, 6.2, percentage and goal, 63%, what their high glucose is, their low glucose. And then you're going to just say any significant lifestyle things. You're documenting that this report has been scanned into the media tab, and then you're sending it over to the provider. I mean, you can also talk about other things that are happening in your chart, other things that you as the educator or nurse, care manager, you can definitely document. But this is kind of what needs to be in there in terms of billing for it. Okay. And then you have to document how much time you spent. Has to be at least 20 minutes to bill for it.
Allison, does that imply that sort of the maximum visit's going to be 40 minutes?
20 minutes or yeah, I mean, you could probably take, I would book an hour for these appointments, you guys, at least initially in your charts. As you're meeting with the patient more and more, you might do a 30-minute follow-up, but especially in the beginning, don't you think, Hugh and Linda and Christina, that an hour is good to set aside for the first few?
yes,
Even though
definitely.
it has to be at least 20 minutes to charge for it, though, to drop that CPT code. Okay. Okay. And then this is what the provider's doing. You've sent the note over, the provider's going to look at it. They're going to do in their chart note, they're going to put this CGM RPM interpretation note, because the provider gets to bill for interpretation of this. And the provider might send the patient an eCare MyChart message. This does not have to be face-to-face, but it could be. It could be in-person, telemedicine, or phone. The provider might also share the note and CC it back to you like a big ping pong game. And you get the note back, and the PCP says, please follow up with the patient with these, with these changes in medication or whatever. Okay. And then if you call the patient back and spend 20 minutes on the phone, guess what? You get to charge for it. Does that make sense? Okay. And then it says here, PCP or whoever's seeing that patient last, there is an AVS note that can be populated to summarize what the changes were. Okay. For the sake of time, this is for maybe Stephanie. I don't know. Have you seen a CGM report before? An AGP report? I don't know, Stephanie.
No, no, I have not.
Okay. So these are just kind of some of the things that you're going to be seeing on these reports. And remember, I was saying you have to document what the time in range is. That's that number there, the time below range, the time. And right there on the right side of the screen, when you are looking at it, you're just going to be pulling that information off that AGP report to put into your chart note. This is the scanning frequency. This is something you as an educator or as a nurse, want to make sure the patient, if they're not scanning at least 3 times a day, at least every 8 hours, there's going to be gaps in their data and they're not going to be getting as much information. And on this patient's chart, you see that on the 5th of September in 2018, they only scanned twice. So we're going to have gaps in data on that day versus the next day when they did 8 times and 12 times and things like that.
Allison, I have a
Mhm.
quick question. When the provider does the referral, they're going to specify what we want to set for the range on their reader, whatever, correct?
I think it comes from the factory as 70 to 180. So I would probably keep it there unless you hear otherwise from the provider, right?
Okay, so they don't have, that isn't included in the referral.
Nope, no.
Okay,
not
got
with
it.
it. Not with this. It would be for
Okay.
a Dexcom, but not for the Libre.
Okay, got it.
And then this is Stephanie. This just shows you, kind of what the daily views, would look like. And on the August 10th, you see there's a big break in data. That's where the patient didn't scan. So they lost all that information. And Stephanie. Stephanie, I'm not gonna, there's this really great, and when you get these slides, there's a YouTube video, it takes 15 minutes. What I would do after you've had a chance to like run around and scream, or maybe tomorrow because your head exploded, I would watch this video.
Okay.
It's 15 minutes that will just kind of show you how to interpret and what's the most important information on that AGP report.
Okay.
At the end, Dr. Subramanian did a 60-minute presentation. Some of the stuff, it was a year ago, is pretty obsolete. I would fast forward through to the second part where she starts reviewing cases and go through the last, 30 minutes of the presentation to look at how she as a PCP interprets the AGP reports. And then you as a nurse, how you would look at it too. Looking at both of those job aids would really help you kind of, do a deep dive into interpretation, and Nikki as well. So,
Okay, sounds good.
yeah, and I'm getting here. So, and then this is that billing and coding chart that I was encouraging you guys to print off. The initial visit is that 95249 that needs to be face-to-face. It's a one-time charge. The 95251 is what is the physician uses when they review the data. Only physicians can charge that 95251. But the 99457, that's the first 20 minutes that you will drop as a nurse or a dietitian when you see that patient in that first follow-up visit. And then the 99458 is additional time that you might spend with that patient. Billed once a month. And then Hugh and Linda, and did you guys ever bill more than 3 times and more than twice in a month?
I don't think you're allowed to, right?
Yeah, I don't think you're allowed. I mean, I didn't.
I could have, because at the very beginning it was taking much longer than 40 minutes for me to do 2 sessions, and I think I touched base with either you or Crystal, I think, who said basically like 40 minutes is the maximum per month. So I never ended up submitting a 3rd bill.
Because you guys can spend more time, but you can only bill for 20 minutes for the first and then into
Right.
the second bit. You know, you can
Yes.
spend 90 minutes with them. Not that we want you to, but you can
I mean,
only,
you can take it at the beginning. I mean, if there's a lot of info going on.
yeah. And that's
could
why
we
they
bill-
decided to split out the 2, you know, for that first visit and the first follow-up. Yes, Becky.
Could we bill a 99211 or if they needed more time? If you're
After you've done those first 2, probably,
Yeah.
I guess. And I guess the dietitians, if you're seeing the patient back for MNT or DSME, I guess you could bill for those times as well too. So, yeah. And then this is just a screenshot of this is that first face-to-face training. You go to charge capture and you type in 95249. And then this is billed incident 2. So the dietitian and the nurse would be the servicing provider, and the physician's name is in the billing provider box to bill incident 2. See, I have the Allison Everett as a service provider. And then this is that first follow-up visit. It's the 95457. And then this is the one that is for the you know, that 3rd visit type, or the third CPT code. Okay. And then what Tammy and I want you to do, at least in the beginning, is to keep track of a list of each month, at the beginning of the month, the name of the patient, the MRN, and the time that you spent. I think Mika has modified the tracking chart for us, but we're going to also use those as a way, Tammy and I, to sit down with each of you to see that the billing's being done correctly, that the chart notes are correct. It's not trying to be overburdensome, and at some point in the future, you know, after you guys get up to speed, we're hoping that you don't have to track it, but at least as it's getting going, we want to work the bugs out and make sure everything's being billed correctly the first couple of months. Okay. And then this is the Epic tool that we talked about, where I want you to each make sure that you can get into those visit types, those smart texts. These are the training videos. This is if you, when we send you the slides and you right click on the remote monitoring, that will take you right to all of the tools that you'll need, and all the files, and the Bible, and the workflows, and the job aids. And yeah, here's a list of all the things that will be in there. And this is just showing you that OPMC. So Christy, you're on the hot seat for that one. And hopefully your providers, when they get trained, will be copying you and Rachel on it, but we're going to put you in the driver's seat on the first one. Ballard, I'm not quite sure what's been decided, Stephanie, since you've been out, and Whitney's only there 2 days a month. Ravenna, Hugh, you're on the hot seat, and then Whitney's adding additional bandwidth if the buses are loading up in the parking lot underground and you have more patients than you can handle. Woodinville, the nurses are on the hot seat, and then KDM, Becky and Deb, you guys are in the front seat on the hot seat, and then we're going to have Nikki in the back seat tagging along. Because Becky, you're going to get reinforcements here 3 days a week in the very near future with your large patient population. And then this is just kind of a rollout of proposed. I'm not sure what's going to happen with the Lopez Clinic and GAMC, because they're not us, but but the tiers, like next spring, and then kind of over the summer. Okay.
Ballard's provider training is tomorrow.
Correct.
Stephanie, are the nurses being invited to that?
They haven't been, Tammy.
Okay.
No.
Okay.
No.
It is the provider training tomorrow. Just
Okay.
like-
Those are the ones that we're creeping on, Tammy, you and I.
I know. Yeah. Okay. But
And typing into the chat box, physicians consenting patients, stuff like that.
it'd be great if Whitney and Stephanie, like you guys kind of talk, especially since you guys are neither one of you there every day of the week.
Mhm.
So you can kind of come up with a game plan. I don't know what we need to find out is, or maybe you guys already know, which providers are interested in this. It's something we got to kind of figure out. Is it all of them? Is it just a couple of them? So I had to talk to Natalia about that to try to help, manage that since neither one of you guys are there every day.
And Tammy, I was just going to share that I'm here today with Nikki and Jeb and Julianne. So I printed them off a copy of the job aid and some of those sheets already. So I'll give Becky a copy of those if that's okay with you, because I made an
Yeah.
extra copy.
Yeah.
And then I'll catch up with Whitney and Christy for stuff.
Hey, can you do me a favor? Can I share my screen real quick?
Yep, I'll stop sharing.
I sent this just so they can kind of see, or actually, I could actually go in Epic.
I've stopped sharing.
Okay, so can you guys see my screen?
Not quite yet.
Can you see it now?
Yes.
Okay, so basically when you go into the flow sheet, so you got to be in an encounter and then you go to the flow sheet. Really all you got to do is go over to the right and you have to type in diabetes. I don't know if it's diabetes MA. No, I don't know if it has to be capitalized or not, but okay. And you have to scroll. If it's not already there, you scroll down to find the GMI. And I'm not going to do that right now. But what happens is when you put that in there, then it populates GMI, time in frame, time below frame, time below range. But that's all you got to do is just type that in there. Okay. It doesn't have the above range, but like Allison was sharing with me the other day, that's not, the patient's not as nearly, and it's not, the danger is the low range. And Allison can explain that better. But I mean, so just so you know, in case someone asks, it was just strategic. It's not to put the time above range in there because that's not as high a risk. Okay. Right. So
I was telling Tammy that, people can die immediately from hypoglycemia, but it takes several years to die from hyperglycemia. So that's where the time below range, we definitely want to have that be always less than 4%. So, yeah.
And the other thing is, just so you guys know, there is the ability to get trends. Some of the providers will want to know that.
That's what I was trying to describe. Yeah.
Okay. All right. Okay.
Yeah.
Well,
Yeah. But to go up to the graph.
Yeah. But it wasn't turned on. We asked them to turn that on. So eventually it'll be there and you'll be able to see a trend, or the provider be able to see a trend in Epic. Okay.
I use that all the time when I was working with patients with weight and stuff like that. So do people have questions in the last 15 minutes?
Just one thing from me, I will include this printout in the new presentation. So later on today, when you get the recording and a link to this presentation and job page, that page that Tammy just showed will be there. So.
And Mika, I'm going to make a couple of tweaks to the notes as we were going through it. I found that there was some typos. I'll try to do that before 1 o'clock. Can I do that? So you can send out the most up-to-date slide set.
It's so funny.
Easier.
It is so funny how many times we've been over this. Allison and I spent 2 hours last week talking through everything. And then you're like, oh, shoot.
What happened? What happened?
No, we're just saying when you're putting together a PowerPoint or something like a training, this has been looked at so many different times. And we had revised it a number of times. But then last week, we went through it for 2 hours together, talking about everything.
Moving
And then,
things around. And then I still found that it says that the physician can consent via e-care, which is now it's my chart. And so, yeah. Any other questions, you guys?
you guys feeling comfortable? You ready to roll?
Stephanie, I don't know, I'm one of the ones who hasn't done it, but I appreciate the outline is, you know, really a lot of information, but I learn by doing. So until I kind of go through it and am with a patient a few times, that's when I will know what I need. But I can tell that there's been a lot of work done on trying to have a workflow. So I appreciate that.
Thank you, Hugh, Linda,
Everybody,
and Christina.
Yes.
Stephanie, if you're, you know, first time you know, if you need to be shown the ropes, like we can do a call. Often Hugh and I really troubleshoot things that way, to like that learn through doing type situation.
Yeah.
So feel free to reach out.
Okay, thank you.
And what
Yep,
we did
same.
with the first group was we set a time like once a month, didn't we, to have a check-in where people had questions. So it was like a drop-in kind of a thing. And Tammy and I can try to connect and create a time. One of us tried to be available for that, just to be a place. But also, to your point, Christina, you know, tagging each other. And Hugh, you were going to say something that I interrupted.
Oh, no, I was just saying to Stephanie, I'm available, or to anyone, I'm available as well to help troubleshoot anything, like what Christina was saying.
Thank you.
Because the dietitians have had a lot of experience on doing CGM, but they have not ever done this billing and scanning piece. So I'm sure their heads are exploding as well. So, but the biggest trick is making sure you start with people that have coverage. So that's the thing that we really honed in on. And Hugh and Linda, I can't see Christina or nodding, but you can waste so much time trying to get a patient covered when they don't have coverage. So, yeah. And
Yeah.
anyway.
So message that to the providers too before they recommend it.
They've got they've got their job aids too.
Yeah,
And
yeah.
that's what they really honed in on. Like,
Yeah.
the providers just have to know this.
Yeah. Yeah.
So,
I mean, I had a provider who thought that because this was a pilot, that we were providing people free Libres. So that was a part of my and I know this provider was a part of every training, you know, but again, we all carry a lot into work with us. So I just said no, they're not on insulin and they have Medicaid and this is not going to be sort of covered. And I just was okay with it. She was frustrated. I don't think she was frustrated with me, but the messenger. So there's just a process of walking your provider sort of through this process. And the next time she brought some of the patient to me, she was like, at least she asked, is this patient still going to be eligible? But still, it was retained nothing from what I said earlier, other than this patient isn't covered. So there might be some of that as well, just kind of continually working with your providers around who's eligible and who's not, in my experience.
and Mika, the one question that I have lingering, which is, let's say Hugh's had people on it for 3 months now, and they're like, I'm good. I don't want to do this anymore. How does the patient unenroll, or do we just stop dropping the charges?
You'll just stop dropping the charges and they will report. And one thing, if they then want to come back later on, then we'll need to discuss how we're going to do that.
You know what? And I have to talk to Crystal about this, because I don't think we ever talked about that. I have found that when you have people enroll in programs, is the wiser best practices to inform them and to have it in some kind of writing that you discontinue the services with them and they were in agreement, because they'll complain.
Yeah.
So we need to probably talk to Crystal about that, to have
that was the one thing I was thinking about, that yeah, because you've had some people in, Linda and Christina, for several months, and maybe their A1Cs are 7.0 now, and they don't need the help anymore. So,
and that's actually totally going to be the case for the folks who are more the worried well, folks who aren't on insulin, who are really interested in like biohacking themselves, right? Like those folks, if you end up having a panel full of those, which it's Ravenna, like my worried well patients, like I want to disenroll you because this is not the most fulfilling use of my time telling you your CGM A1C is 6.8, like 6.3, like great, keep doing it. You're on your own now. Like, so I think Tammy, what you're saying is right. I think figure out a way that we can also be able to disenroll patients who perhaps are ready to move on.
Right. So you said worried well, and what was the biohack? What was the other
like biohacking people who are like, it's people who are really interested in like optimizing every little bit of their life.
Biohack. That's going to be my new favorite term.
Yeah. Like there's a whole trend of people who don't even have diabetes that want to be on constant CGM. Like I'm pretty sure Mark Zuckerberg is using like CGM and like wants to track down his sugar like every minute, and like, oh my God, I will die if that's who I have to end up working with, all the time. So,
it's exhausting.
Exhausting. Yeah.
Just exhausting.
It's such different ends of the spectrum, right? Than the people
totally
that really need it. And yeah.
We don't biohack down here in Kent, Des Moines.
I don't think so.
I see that at South Lake Union sometimes and Belltown. Yes.
I'm borderline on that spectrum. So the CGM was not good for me. We had to practice with it.
Same.
So Stephanie and Rachel, in both of your managers' offices, there are some Libre samples for you. We can't give them to patients, but maybe Stephanie, like you could sit down once with, Whitney, maybe when she's in the office the next time, and she can show you how to get started, or just be there with you when you start it for the first time. And then Rachel, maybe you can make a date with Christy sometime because I think that there's such rich learning, and Mika and Crystal did all the paperwork to enable you guys to get that. Because Linda and Christina, wasn't it just so informative?
And I loved it. It was really fun. I mean, interesting for 14 days. I had it the whole time. Yeah.
Yeah.
Cool.
So, yeah. So I guess we give you back 6 minutes unless anybody else has anything else to say. I don't think there'll be busloads of people, but I think there'll be a few.
And I'd anticipate this is the wave of the future too, right? Like in terms of coverage, and Medicare will hopefully, and Medicaid eventually get more of the program, because it'll save them money in the long run. So it's just.
And then, for the patient that doesn't want to be in it, you guys have all been trained on coverage. Because I mean, people use CGM that are not part of the remote monitoring pilot, but what you're learning will be able to help you with those one-offs for people, that don't want to do it, right?
Yeah.
But getting them set up on the LibreView account facilitates the provider being able to go in an appointment in a one-off, and looking at the data and evaluating it too, and you too.
Yeah.
So yeah, because there's going to be a lot of patients that'll be using CGM that won't be part of remote monitoring. So yeah.
I've had people ask if we can do the Dexcom, and I just, I don't know if you want to say to that, Allison. I always say we don't do it here. We just do the LibreView.
Yeah, with the Dexcom, it requires a certificate of medical necessity, which is, if you think a DME is a lot of paperwork, we just don't have the bandwidth in primary care to do that amount of paperwork for a CMN, certificate of medical necessity. It's just mind-boggling.
Yeah.
They're very, very expensive. Very expensive.
$1,000.
$1,500 was this guy that I was supposed to see on Friday. Yeah.
And you have to
use like 150 or something out of pocket to start.
Yep. So the paperwork is the main thing. Yeah. We just don't have the bandwidth. So, but good question. Yeah. Send him down to the DI.
But I do. Yep. Perfect.
Yeah. Okay. Sayonara.
Thanks
Bye-bye.
again.
Thanks, everybody.
Bye.
Thank you.